So next is our video number 6. It's about randomization. So I think we should just remember the name of different techniques. But first is, what is RCT? So this type of study design permits comparison of two or more possible interventions, and participants enrolled in the study are randomly allocated to one or other treatment arm. Two, minimum two interventions. Apart from the intervention being tested, all other care received by the participant should be intrinsic to the treatments being studied, properly conducted and reported. RCTs provide 1B evidence of efficacy. What are the advantages and disadvantages of RCTs? So the advantages, first, there are so many advantages. Number one, key advantage is that the randomization should minimize the risk of introducing bias, especially allocation bias, into the study by balancing both known and unknown prognostic factors between the arms of the trial. Number two, properly conducted trials have high internal validity. The causal relationship between the two variables is demonstrated, and a causal relationship can be inferred where that supposed cause precedes the effect in time. The cause and the effect are related, and there is no other potential explanation for the observed cause-effect relationship. And point number four, the results of RTCs can be combined in the systematic views to provide level 1A evidence of treatment's efficacy, thus guiding the healthcare policy. And point number five is, internal validity is often very good, external validity is often limited. And point number six, external validity is the extent to which the trial findings can be applied outside the setting of actual trial. That is, the generalizability of the trial finding. Means in clinical practice we can apply these trial findings. So how we should generalizability of the trial findings. And the next advantage is that the external validity may be affected by the physical location of the trial, exclusion criteria that render the trial population different or more selected, and time and cost are two other frequent limitations. It is often difficult to continue the trial for time necessary to obtain the long-term follow-up data, and trials often tend to focus on one narrow area of the patient condition and thus may not be reflective of complex medical condition. Next question is, what are the different phases of randomized trial? Very important. High yield for Viva. So phase 0 trials are exploratory, first in humans, usually with a smaller number of participants, and subtherapeutic doses are given to see the how drug behaves in the humans. And phase 1 trials, again, it's aimed to determine the primarily whether intervention is safe and whether it has beneficial effect. It usually involves 20 to 100 healthy volunteer. This is phase 1. So again, phase 0 was a small number, maybe a 10 dozen, to see the subtherapeutic doses and drug, and phase 1 beneficial effect of intervention is safe and the volume of the sample is 20 to 100. And phase 2 trials are conducted in a larger group up to the 300 patients after safety has been established in the phase 1 trial. And phase 2 trials has two, phase 2A and phase 2B. Phase 2A trial aims to establish dosing requirement, while phase 2B study aims to establish efficacy. And phase 3 trials are large multi-centric trials which aim to evaluate the efficacy of new intervention in clinical practice. They are complex, they are expensive, time consuming, but provide robust evidence of efficacy. So all phase 3, they are multi-centric. And phase 4 trials are conducted after intervention has been licensed for the routine clinical use. They are also referred to as the post-marketing surveillance. Okay. And next is the, what do you understand by intention to treat as opposed to per protocol analysis in a randomized trial? Again, very difficult question for me. Intention to treat analysis is a comparison of the treatment group that includes all patients as originally allocated after randomization. This is a recommended method in a superiority trials to avoid any bias. Pre-protocol analysis is a comparison of the treatment groups that includes only those patients who completed the treatment originally allocated. If done alone, it leads to the bias. In non-inferiority trials, both intention to treat and per protocol analysis Intention to treatment are recommended. Both approaches should support non-inferiority. Okay guys, so here finish we RCT. Next is randomization techniques. So this was actually I was talking about that we should name the remember the name of the randomization, but the previous so far is about RCTs. So randomization techniques. What types of randomized trials are you aware of? So randomized trials can be classical by the trial design. There are four main types. So there are four types of randomized controlled trial. Number one is a parallel group trials that participants are assigned to a group and all members of that group then receive or do not receive an intervention. So number one, parallel group trials. Number two, crossover trials, like each patient receives the intervention and then does not receive the intervention in a random sequence over time. Then is factorial trials are used when there are several elements to the intervention under investigation. Participants are randomly assigned to groups with different combinations of differing combinations of intervention elements. I think this is what we do. And then is the cluster trials. In pre-existing groups of the participants are randomized en masse to receive one intervention or another. Entire wards are randomized to use a new or old type of hand wash. Cluster trials. Cluster, so you're checking a cluster with only one intervention. So what methods are available to randomize patient taking part in the trials? So again, there are 4 points. Number one is a simple randomization. Commonly used, it's similar to like a coin tossing. You don't know which one. And disadvantage is that it may result in an imbalanced distribution of key confounders and a planned recruitment of more than participants. For simple randomization, we should more than 200 people. Then is a restricted randomization, is used in the smaller trials. This may include block sizes with localized randomization ratios. Restricted randomization is often combined with the stratification, in which separate randomization schedules are prepared for use in the participant according to the presence or absence of key confounding factors. Then is the random allocation. So number one was simple randomization. Number two, restricted randomization. Number three, random allocation is a special type of restricted randomization in which entire blocks of patients are allocated to one or other arm of trial. Then is adaptive randomization, is used infrequently, so let's don't talk about it. What is allocation concealment? Allocated and then concealment, very simple. So allocation concealment refer to the procedures used to ensure that the trial assignment of the next recruited participant remains unknown before successful recruitment of the patient. And successful allocation concealment is considered critical to minimizing the selection bias in the trial. Various methods are available, including the sequentially numbered opaque sealed envelopes. Ideally, randomization should be undertaken by third party not involved in the recruitment of the care. How does the allocation concealment differ from blinding? Again, very good question. Allocation concealment is the method used to prevent clinicians working out the trial allocation of the next patient, while blinding refers to the intervention under investigations. In a blinded study, combination of the clinicians, patient, and outcome assessors are unaware of whether the patient has received one intervention or not. So it's in placebo versus intervention. Allocation concealment should always be. Next is let's finish here.